We are live.
Very good evening, everyone. Welcome to lecture 495 of the refractive surgery module. Today, the topic will be legal implications in refractive surgery practice. For the session today, I would like to welcome our moderator for the session, Dr. Ritika Mukherjee. She has done her MBBS in 2016 from Rohilkhand University, Uttar Pradesh, followed by MS Ophthalmology in 2021 from Jawaharlal Nehru Medical College, Wardha, Maharashtra. She finished her fellowship in cataract and refractive surgery from Narayan Netralaya, Bangalore. She is also a ratified member of the AIOS and Delhi Ophthalmic Society. She's published various articles in national and international journals. She's also won numerous awards like the Best Poster at International CXL Meet in December 22 at Zurich, Switzerland. Also the Best Poster at ESCRS 2023 Vienna, Austria. She has also received the Siva Hadia Award for the Best Paper in Refractive Surgery at AIOC 23, the Best Papers in Innovation and Refractive Surgery at IRSI Delhi 2023, also the Best Papers in Free Paper Session at DOSCON 2024. Welcome, ma'am.
Thank you, Garvita. I would like to take this opportunity to introduce our chairperson for today's session, Dr. Kiran Kirtani ma'am. She completed her MBBS from BJ Medical College, Ahmedabad, and her MS in Ophthal with a gold medal from MNJ Eye Institute, Civil Hospital, Ahmedabad. She completed her senior residency at DDU Hospital, New Delhi, and is currently serving as a senior consultant at the Center for Sight Eye Hospital, New Delhi. She's trained and certified femtocataract surgeon as well as a refractive surgeon. She is the organizing secretary of prestigious PG training programs, including iFocus, and the organizing secretary of IRSI. She also serves as the faculty for iFocus, IRSI, and various other conferences, and has authored book chapters and publications in multiple index journals. Thank you for joining us, ma'am. Now, I would like to introduce our speaker for the day, Dr. Ritika Mullick. She is a consultant for cornea, ocular surface, and refractive services at ICARE, NOIDA. She completed her MBBS and MS ophthalmology from Lucknow, and as well as a long-term fellowship in cornea, ocular surface reconstruction, and neoplasia, refractive surgery, and translational research from Narayana Netralaya, Bengaluru. Her areas of special interest include advanced imaging techniques in refractive surgery, keratoconus management, corneal transplantation techniques, ocular surface diseases, and dry eye management. She has multiple peer-reviewed research papers and has been an active faculty at multiple national and international conferences. She also has multiple awards for paper, posters, and video presentations on both national and international platforms to her name, and is the recipient of the International Ophthalmic Heroes of India Award at the AIOC 2022. Welcome, ma'am. I'd like you to share your slides now so we can start with the lecture.
Thank you for the kind introduction, Dr. Ritika. And thank you, Dr. Kiran, for joining us. I would like to thank you for giving me this opportunity today and such a nice platform iFocus gives to PG residents and to doctors all over the world. So can you see my slides? I can't hear you, Ritika.
Yes, your slides are visible.
Okay, so I'll be putting it on full screen. Is it okay now?
Yes.
Okay. So I will be talking today about legal implications in refractive surgery practice. So it is a very broad and generalized topic, but I have tried to summarize all the topics in different headings. So firstly, I would introduce medicine as it's not only a science, it is also an art. It requires a kind of compassion which is not required in any other field except for being a doctor. It does not consist of compounding pills and plasters only. It deals with the very process of life, which must be understood before they may be guided. So with this introduction, the practice of ophthalmology has advanced exponentially due to its technology. This has raised the bar of medical care from acceptable visual acuity to the highest precision in acuity. In such an era, it is the need of the hour to be aware of the medico-legal implications in ophthalmology to avert any lawsuits. So lawsuits can be due to breach of confidentiality, inadequate consent, negligence, unmet expectations in a procedure, or some other factors of negligence. So the awareness of regulations can guide the healthcare professionals in such instances. These include the knowledge of laws governing every step of practice and the rights to both healthcare professionals and patients. In addition, clear communication regarding the risk benefits, and outcomes of the procedure, strict adherence to guidelines and meticulous documentation are effective tools to avoid litigations. So why are there so many cases against doctors? So as we know that refractive surgery has very high expectations. The patient is 6 by 6 while wearing his glasses and he wants to be better. We are promising these days as a very quick procedure. We are giving eagle eye vision. We are promising a lot of technology, and excessive marketing is going on with a lot of YouTube videos shared by doctors itself who show the procedure in advance to the patients. So the patients come with a kind of a mindset that they'll be going with supervision, and over promising and under delivering, creating a mismatch in the expectation is the main cause why there are so many cases against the doctors. So, what makes a patient unhappy? Obviously, the complications during the procedure. If we missed any history of the patient, any amblyopia which was undetected, and we have not explained to the patient that his vision will not be correcting after the surgery. And we did not simply meet his expectations. We promised a lot and we just did not deliver. And the main cause of these patients being unhappy is also dry eye, which should be ruled out in a very, very thorough examination before proceeding of surgery. So, how to prepare a medical report? You should have detailed notes of examination, treatment plan for execution, signature stamp with updated medical council number from the state you are practicing. So these days for the Ayushman Bharat patients, we need to have a UP medical council with additional qualifications required if we are practicing in UP. Such these states are also these laws are also in other states, so we have to be very careful about where we are practicing and what stamp we are putting on the patients. So records should be as thorough as possible. Note the date and any changes to the chart for any other reason. So thorough documentation is the key to such procedures. So next we come to a very important history taking point. I will not cover all the history taking points, but the very important ones such as occupation of the patient. So always confirm the occupation of the patient, because these days a lot of patients want undetectable surgery as they are going for some police exams or aviation exams, or they want to go for some combat type of a professional field. So we have to take a detailed history about what they are planning to join in further. So professional drivers, pilots, military officers, police officers must understand the limits of the treatment that is proposed and whether it is prohibited in their profession or not. If authorized, how long this may prevent them from resuming work. For instance, in the US, pilots with a Class 1 license undertaking LASIK may be restricted from flying up to 3 months, dependent upon satisfactory examination and refraction by a CAA registered ophthalmologist. Such rules are not clearly given in the Indian laws and the medical ethics, but we should always confirm by the patient and what is allowed and not allowed in his profession. The medical professional and autonomy. So, health is a fundamental right given by the Article 21, guaranteed by the Constitution of India. An ophthalmologist is a medical professional with a high degree of skill, knowledge, and expertise involved in eye care, which is also read as health. The medical profession is regulated these days by the National Medical Council, which is the NMC. So this is a new regulatory body which has replaced the previous regulatory body of the MCI, which was the Medical Council of India, through the National Commission Act of 2019, which is Act 30 of 2019. So the NMC comprises of 4 autonomous boards that regulate undergraduate and postgraduate medical education, medical ethics, registration, and grievance redressal mechanism. So what is ethics? As told by a very famous lawyer, Mr. Peter Swart, ethics is knowing the difference between what you have a right to do and what is the right to do. So, ethical regulations. All medical professionals are bound by the Hippocratic Oath and the Code of Medical Ethics 2002, which governs all activities of the profession, including medical intervention, interaction with patients, colleagues, and staff. Unethical soliciting, advertising, or receiving personal gifts in cash or kind from pharmaceutical or medical device companies would amount to misconduct and render a doctor liable for disciplinary action by the respective state medical council and National Medical Commission. So next we come to a very important point of our avoiding our lawsuits is the consent. A watertight consent should be given to a patient. So a patient's bodily autonomy must be respected and his or her right to privacy is guaranteed by the law. Any examination, investigation, or treatment must be undertaken only after an informed consent. So, for example, if a patient comes for a routine eye examination in the outpatient clinic, for a patient who walks in voluntarily, implied consent would suffice. We do not need to take a signed consent. But for any invasive procedure, such as YAG laser or any surgical laser treatment, we need an express written consent, which is advisable. So, elaborate video or handwritten consent is not considered essential, but adequate prior information regarding the nature of the disease, investigations, risk, benefits, outcome, and alternatives to the management options should be provided before the patient signs the consent form. So the patient must have an age and mental capacity to consent. For children less than 18 years of age, parents and legal guardians can provide the consent. Proxy consent from the next of kin should be considered in certain situations wherein the patient is not able to sign the consent form. The consent taken for one procedure cannot be considered as a blanket consent for additional procedures. For example, in other ophthalmic procedures such as trauma or globe rupture, first aid and primary treatment can be undertaken without consent. But in refractive surgery, all steps of the procedure has to be written down in the written watertight consent. So this is a consent of our institute, which shows that the correct particulars of the patient should be filled, such as the name of the patient, age, gender, the MRD number generated by the hospital, the date where the operation is taking place, the guardian's name, and the address and contact number. Then explanation of the procedure which is going to take place should be in the introduction, which can be either femtocontura or photorefractive keratectomy or any lenticule procedure or any ICL procedure which can be presented to the patient. Then the expected benefits should be told to the patient in clear words, such as femtocontura is to, for example, it is written that the purpose of femtocontura is to reduce short-sightedness, long-sightedness, or astigmatism to provide me a better unaided vision that I presently have with or without spectacles or contact lenses. However, I understand that an excellent unaided vision may not be guaranteed. So this should be explained to the patient, and also alternative treatments should be explained to the patient. A detailed explanation of all the associated side effects such as undercorrection or overcorrection, presbyopia in the future, drop in the visual acuity may be due to some scarring, infection or dry eye, glare, starburst or double vision, and rare complications such as infection, inflammation, corneal edema, loss or damage to the corneal flap should also be mentioned in detail. Long-term changes should be mentioned which require spectacles or contact lenses in the future, and any technical failure which is not in the hands of the doctor, which may lead to abandoning of the procedure, should also be mentioned in the consent. And elaborate all the potential complications in all the points which the patient has to read and go through. Post-operative precautions should also be elaborated. Next, when the consent of the patient is there, we should mention the doctor's name and the eye which we are choosing, either the left eye, right eye, or both the eyes. Finally, the patient's signature with a witness signature, one or two witness signatures are enough, and declaration by doctor with doctor's signature and stamp with registration number should be there according with the correct date of the procedure. Next, we come to confidentiality, medical records, and data privacy. So patients have the right to privacy, and the medical history, investigation reports, or treatment details should not be divulged to anyone else other than the patient. Exceptions including obtaining consent from the patient required by the law or for discussion with colleagues or staff involved in the treatment. According to the Code of Medical Ethics 2002, medical records should be maintained by the hospital for a period of 3 years minimum. In case of medical legal cases, records must be maintained until the completion of the legal proceedings or even indefinitely. Copies of all the certificates issued for fitness and visual handicap must be maintained in a register. So this is given by the Ministry of Law and Justice in the Government of India. Any written request for copies of medical records from the patient or a legal authority must be compiled with, and details must be furnished within 72 hours in the minimum. Public hospitals, medical colleges, private hospitals, and clinics now come under the purview of the Right to Information Act and are also guided by the provisions of this Act. With the digitization of records by most hospitals, privacy policies and regulations of access to medical records have been more important and are governed by the Information Technology Act of 2000. Then records suggested to be maintained are the informed consent or any refusal of the treatment or the investigation by the patient. And the reason for refusal should also be mentioned in your documents. Investigations such as pathological, radiological, referrals, or any opinions of other specialists should also be documented. Any operative details, such as details of the surgery, steps of surgery, date, operating surgeon, anesthetist, concise pre-op and post-op notes, condition on discharge should be noted. Discharge card clearly mentioning follow-up visits and emergency signs for patient to report. And any referral done for the patient. The referral should mention the date, the nature of referral, probable diagnosis and condition at the time of referral. Reason for referral and prognosis should also be mentioned, and it is wise to get a copy signed by the patient also. Negligence and liability. A medical professional is expected to bring to his task a reasonable degree of skill and knowledge along with a reasonable degree of care, but neither the highest nor lowest degree of care or competence. Once the doctor accepts to undertake a patient for treatment, he owes a duty of care. Negligence is a breach of duty of care owed to the patient. A doctor should be held liable only where his conduct fell below the standard of a competent practitioner in the field. A difference of opinion or choosing an alternative course of treatment when more than one standard of treatment option is not considered as negligence. Guidance on standards of care is periodically devised by professional body. In case of ophthalmology, the All India Ophthalmological Society, which is the AIOS, publishes standard treatment guidelines for ophthalmic conditions regularly. Also, the Clinical Establishment Act prescribes guidelines for the practice of various subspecialties. A doctor can be held liable for negligence at various levels depending on the magnitude, including the tort law, which is in the civil codes, consumer commission and criminal negligence, which is under the Indian Penal Code, in addition to penalization by professional regulatory bodies. This was given by the Ministry of Health and Family Welfare in the Government of India, described in the Clinical Establishments Act of 2010. What are the key points for negligence, such as the breakdown in communication between a surgeon and a patient and the team? It was not relayed properly that what procedure is supposed to be done and how it's to be done. So there is some kind of a miscommunication between the patient and the team. Lack of verification, such as incorrect refractive error. The laser firing has been fired incorrectly. Inadequate validation of sight, such as the wrong eye has been operated, and inadequate preoperative checklists, incomplete patient assessment, and language barrier between the staff or within the staff itself. Improper consent, consent which is half finished or a blanket consent has been taken which does not mention the complications or side effects, and failure to maintain the medical records. The Consumer Protection Act of 2019, which is the COPRA, gives a right to consumers to file a complaint with the district commission wherein the services availed by the consumer suffer from any deficiency or negligence. Under the law, deficiency includes any act of negligence or omission or commission by such person which causes loss or injury to the consumer. We will discuss some examples which have been taking place, which is Amit Kumar Rohela versus the Sun Eye Hospital and LASIK Surgery Center, which was in 2021. This was under the forum of the National Consumer Disputes Redressal Commission, which is the NCDRC. And the facts of the issues of the claim were medical negligence in LASIK surgery, where the LASIK surgery resulted in retinal detachment of the complainant's left eye. And also they said that there was a decentered ablation. It was upheld in the court, which saying that there was a breach of duty by the medical practitioners Discharge summaries lacked comprehensive advice, particularly concerning the use of contact lenses post-surgery, which is a critical factor in the retinal detachment. Lack of due diligence, the hospital failed to refer the patient to a higher medical center in a timely and professional manner, for which the retinal detachment exceeded and leading to blindness and loss of vision. Key takeaway is need for thorough documentation and appropriate post-operative care instructions for all patients. Next, we come to a landmark case, which was Prasanna Lakshmi versus the Max Vision Laser Center Private Limited in 2019. This was also under the NCDRC. The complainant where the flags on issues of the case was that the complainant was not briefed about the risk involved in the surgery and was only assured that the surgery was a safe procedure and had no complications and was a bladeless surgery. The day after the surgery, there were no senior doctors available, and a junior doctor explained her but did not mention the presence of microstriae. Complainant had experienced loss of vision both in clarity and quantity and further suffered severe glare, contrast sensitivity, hazy vision, and light distortion. Also, there was decentered ablation, which was also claimed by the complainant. So, which was upheld in court was that the informed consent form did not mention the common complications such as dry eye or any other complications. No proper advice was given for correction of the post operative complications either by the treating doctor or by the LASIK center. The treating doctor did not administer the proper duty of care, thus, negligence was found. So, what is the key takeaway from this case is that medical professionals, while performing LASIK surgery, should at least explain the common complications like dry eye, and example, any other complications such as microstriae or some decentered ablation, also due to any technical failure or any other problem prior to the performance of the surgery. So next we come to a very important question asked by our patients: is insurance in refractive surgery? So first we come to insurance and ophthalmology. So health insurance in India has traditionally been regulated by the IRDAI, which is the Insurance Regulatory and Development Authority of India. So the IRDAI, which is the health insurance regulations, along with the guidelines on standardization in health insurance, guide the healthcare providers on the norms to be followed while servicing eye care consumers. Alternate grievance redressal is by the officers of the insurance ombudsmans under the administrative control of the Council of the Insurance Ombudsmans, which is the CIO. Next, we come to the TPA, which is the third party administrator, which is an insurance intermediary licensed by the authority who either directly or indirectly solicits or affects coverage of underwrite, collect, charge premium from an insured or adjust or settle claims in connection with health insurance. So, eye care professionals need to understand that cataract surgery related claims are related to the pre existing disease clause, the sum insured, sublimits for cataract as per policy, and the co payment issues. So, this may vary from patient to patient or the insurer or the insurance company which the patient has taken it from. Hence, the service provider must understand that the patient policy and the admissible under the policy before providing service or raising a pre-authorization for a cashless scheme. So IRDAI has defined pre-existing diseases means any condition, ailment, injury, or disease that is or are diagnosed by a physician within 48 hours before the effective date of the policy issued by the insurer or its reinstatement, or for which the medical advice or treatment was recommended by or received from a physician within 48 hours before the effective date of policy. So next we come to an important point, which is the insurance in refractive surgeries. So in cases of refractive surgeries, claims are admissible only beyond minus 7.5 diopters spherical, and less than this is generally not considered by the insurance companies as it is considered as a cosmetic treatment. However, LASIK refractive surgery treatment reimbursement claims have been refused by certain companies as it is considered to be a cosmetic surgery and therefore excluded for refractive errors of less than 7 diopters. However, in an individual case, the Consumer Disputes Redressal Committee had opined that LASIK laser surgery cannot be considered cosmetic surgery and that the patient may be reimbursed for such a treatment. Therefore, a patient may seek legal recourse from a case-to-case basis. Such examples can be seen by the judgments of the Delhi State Consumer Disputes Redressal Committee, where the Royal Sundaram Alliance Insurance Company versus the Suchi State case was there in 2017. Instances where claims for full reimbursement of treatment costs have been refused by insurance companies and paid after court interventions, such as in the case of Akansha Jain, where the insurance company had to pay 1.11 lakh to the complainant. Insurance difficulties. While working with insurance companies and TPAs, ICARE service providers need to establish clear policies like defining roles and responsibilities, specifying performances, metrics, and setting expectations for communication and reporting. Monitor performance by tracking key performance indicators such as the KPI indexes, like claim processing times and accuracy rates. Leverage technology like implementing electronic medical health records such as EMRs to streamline claims processing or using data analytics tools to identify areas for improvement. And also maintain a strong relationship to facilitate open communication and collaboration between the insurance and your clinic. Next, we come to professional indemnity insurance. So, the main cause or the reason for professional indemnity insurance is to protect yourself. So, within the healthcare coming under the purview of Consumer Protection Act, medical professionals are liable to be sued for negligence. Consumer forums such as this district, state, or national is a preferred and less tedious route for a patient to seek quick redressal. Several cases have been reported against ophthalmologists and decisions have been taken by the NCDRC. In a study of the 942 cases decided by the NCDRC from 2002 to 2018, 30 cases pertain to ophthalmology, and about 73.3% of the alleged cases of medical negligence in ophthalmology were proven. So, ophthalmologists are being increasingly sued for large compensation claims, and refractive surgeons are under the guns for this. And it has been advised that adequate annual indemnity insurance cover should be taken, which should cover the negligent acts or vicarious of the subordinate staff, nurses, junior doctors, and also consultants. While the exact amount of the indemnity cover would depend on the level of practice and risk undertaken by the doctor, it would be prudent to keep in mind that future claims for compensation could range from up to 50 lakh to several crores of rupees. So we should remember that given by the Chief Justice of India bench, in the court of law, a doctor is not guilty of negligence if he has acted in accordance with the practice accepted as proper by a responsible body of medical men skilled in a particular art. It is also held that in the realm of diagnosis and treatment, there is ample scope for genuine difference of opinion, and a doctor is not negligent merely because his conclusion differs from that of another professional man. It is also made clear that the true test for establishing negligence in diagnosis or treatment on the part of a doctor is whether he has been proved to be guilty of such a failure, as no doctor of ordinary skill would be guilty or if acting with ordinary care. In cases of criminal negligence, where a private complaint of negligence against a doctor is filed, and before the investigating officer proceeds against the doctor accused of rash and negligent act, the investigating officer must obtain an independent and competent medical opinion, preferably from a doctor in the government service or qualified in that branch of medical practice. Such a doctor is expected to give an impartial and unbiased opinion, applying to the primary test of the facts collected in the course of investigation. Honorable Chief Justice suggested that some statutory rules and instructions incorporating certain guidelines should be issued by the Government of India or the state government in consultation with the Medical Council of India in this regard. So, some take home points: maintain a good communication with your patients, explain thoroughly the procedure. Do not overpromise, do not overmarket your procedures. Do not tell him it's a very quick procedure, it will take only 5 minutes. Give him expected timeline and also expected benefits out of the procedure. Maintain a proper, thorough documentation. Note down the history of the patient, all the detailed examination. Get a thorough retina examination done. If you suspect glaucoma, get a glaucoma examination done and run all the tests and explain the side effects in the future for the patient. Effective counseling. Preferably do the counseling yourself and do not leave it to your counselor or the staff. Maintain your counseling points for the patient and explain all the questions which the patient is asking you. Own your complications. Do not hide your complications. Always explain to the patient what has gone wrong and try to get early intervention in such cases. If you try to hide the complications or try to shirk the complications, the patient might get a second opinion and then come to you and sue you for your kind of negligence. If you get a patient who has a negligence from some other doctor who has referred a case, do not badmouth the other doctor and do not say that I could have done this better and you should have come to me in the first place. Always maintain a kind of decorum for as a professional. Take the consent in the local language, which is best explained to the patient, and have multiple languages for your consents for signature also. Treat to the best of your ability and do no harm. Involve a team of specialists if it is beyond your capability, and always have a professional indemnity. Thank you.
Thank you, Dr. Ritika. You have explained it really well and given us in very concise points what should be said to the patient, how we can protect ourselves. You made a very valid point that we should always speak to the patient very clearly from the outset, because refractive patients tend to come into this with the hope that this is going to be a quick fix and I will
Yes.
not have to wear my glasses, I will have supervision the very next day. But you should always temper their expectations, under promise and over deliver.
Yes.
Kiran ma'am, any thoughts from your side?
It's a very, very nice presentation. And there are a lot of things which we are taking back home today. I would like to ask you one question, which is a very common question which we tend to see in our OPDs, especially for the patients who are coming for a refractive surgery correction in view of the fact that they are applying for Army or Air Force or military or any other government jobs. So
Yeah.
what is your take on that? What is your recommendation? What is the standard of protocol or care that you're using in your institute or at the places where you have worked earlier?
So we do not promise the patient. The patient generally comes to us 10 days before his medical examination and he suggests that I want 6/6 vision. After 10 days is my examination and I do not want a detectable surgery. So these are the two top demands what the patient comes with. So first things, I explain the patient that one, the vision coming after the surgery is totally dependent on how he is going to recover. We will do to the best of our ability, we'll do the procedure. And second thing, if he wants an undetectable surgery, we do not promise him that it is not detectable by the medical professionals who are going to check him later on. But we do tell him that you can go for an epicontura or such as a PRK procedure. But we do not promise him that there won't be any scarring in the future if the number is very high. So these are the 2 points which I make sure. And obviously, I tell them to put some time in their hands, maybe take 1 month for recovery if they are undergoing a PRK procedure, not just 10 days for their procedure. So, yeah.
And in many of these cases, the requirement is that in a lot of government jobs, they are allowing LASIK,
Yes, they are.
but there is a time gap of approximately a year or a
Yeah.
gap of 6 months,
Yes.
which is asked for. So yes, PRK or epicontura can be performed, but the patient needs to be adequately warned about
Yes.
the recovery time, especially in cases where we are doing an epithelial breach. So how the patient is going to respond and how is going to be recovering
Yes.
can be very, very variable in such cases.
True.
But especially in cases of Army, Air Force, or military, I think it is highly unlikely that any procedure apart from epicontura or PRK can be performed,
Can be.
because there it's a definitive requirement that there should be no flap-based procedure.
Yes.
However, in India, to best of my knowledge, there are no clear guidelines.
There aren't any clear guidelines, ma'am. I
Yeah.
checked everything, even for aviation. They do not allow anything, but I've seen pilots undergoing epicontura procedure before the examination and just passing for the 6/6 vision, which is also unethical on their part.
Yeah. And besides, there is no time gap which is clearly
Yes.
mentioned.
There isn't
How
any
can
time
they,
gap. Yeah.
how early can they join?
Yes.
Right.
And also,
Garvita?
I feel we should tell these patients that sometimes they check the axial length also, because sometimes they are under the impression that they'll just be under a torchlight examination. So the patient
True.
might later come to you and say, "But they found out you told me that they will not know that there is no flap or anything. So how did they know?" So that is something that I think should be mentioned to them.
Yeah.
But many places, especially in Air Force and in Navy, the cutoff of 25 diopters, rather 25
Millimeters.
the axial length
Yeah.
is definitely there. That if the axial length is exceeding this, and the patient, despite the fact the patient may be having a 6x6 vision post vision correction, patient who is having a longer axial length is many a times contraindicated from any of such services. Right. Garvita, do we have any questions that we are having on the platform?
No, ma'am, no questions on the YouTube and or the Facebook platform.
So Yamini is asking here, um, after how many days exactly can we promise the patient 6x6 vision after PRK? First of all, Yamini, you
We
never
never promise the
6x6.
patient anything.
Never promise 6x6.
Never promise 6x6.
Yes.
Or take ample amount of time in your hands, because how the epithelium will react after surgery, nobody knows.
So any patient of refractive surgery or
Yeah.
cataract surgery, for that matter, your quest is to reach the 6x6 mark. Your question always for any patient who comes into your OPD is why not 6/6? However, your promise will never be 6/6. That
Yes.
is something which is the most important take home for every ophthalmologist who's sitting right now and listening to this lecture. It's always better to under promise and over deliver rather than getting into a soup later. Right. Any other questions that we have?
So I have a question in terms of, so most of these refractive patients, they tend to have complaints of glare, and they have complaints about their near vision, especially the high myopes. They always come back saying ki my near vision is affected. So do you have any tips on how to temper those expectations? Because obviously we are not even touching their near vision, but they always say that this is an issue.
So firstly, for the glare, always note the pupil size. So a good pupillometry and good optical zone. If we are doing a flap-based procedure, the flap should be at least 9. So we are taking a 6.5 optical zone with an ablation zone of maybe 8.5. So make sure you note the pupil, and also tell the patient that maybe in driving in a few days after the surgery, you might get some glare, but that will go off in a couple of months or so. Put him on high lubricants and immunomodulators if it's not properly going away. And second thing, what you said about the near vision is I always tend to do a good orthoptics examination to see how their near vision accommodation is. And if the orthoptics is poor, I explain the patient that the orthoptics is poor and give him some home-based or office-based exercise and then proceed for the surgery. I think that will be a much safer option before going for surgery. So give him some time, 6 months, to do the exercises, recover on his orthoptics, tell him some exercises which he can do at home, tell him some tips where he can put the reading light and everything, and then maybe proceed for surgery. That will be a better option.
Right. There's another very interesting website which tends to help you in, showing in simulation as to how much is the pre-existent glare, starburst, or halos that a patient is seeing, even with his best corrected vision, even before he has undergone a surgery. So there are papers which are clearly mentioning that most of the patients who tend to complain more about glare and starburst post-surgery are the ones who had this as a pre-existent condition itself.
Yes.
So it is just that because now a surgery has happened, the patient will tend to correlate it more with the fact that a surgery has happened and now I'm having a problem. And the web is replete with this information. So you can, as a matter of practice, you can include this in your clinical workup and show to the patient what is this pre-existent level of glare, starburst, or halos, which the patient is already seeing with his glasses. So that simulator has both day vision and night vision. Following which, after surgery, the same, how much is the actual increase, the patient will be able to decipher. Also, if the patient is experiencing glare or phenomena, optic phenomena, especially at night while driving, you can, for the initial part, give patient some pupillary constrictors. You can give him something like a brimonidine eye drops while he's driving, so the pupil gets constricted, or ask him to switch on the dashboard lights inside the car so that the pupil gets constricted and the glare which is coming from onward vehicles or from lights on the streets is not affecting him that much. So that is one important aspect. And I wanted to ask you about the optimization of the ocular surface. So you mentioned that dry eye is, of course, one of the most important reason why patient tends to have a post-operative dissatisfaction. And there are cases where patient tends to travel from doctor to doctor post-refractive,
Yes.
just trying to find the actual treatment for a dry eye. So how do you optimize ocular surfaces in your patients of refractive surgery before you proceed for a procedure?
So first, most of the time I do a thorough dry eye checkup, that is there any pre-existing dry eye or not. And obviously, if there is a pre-existing dry eye, then I put the patient on preservative-free drops and also some cyclosporins. So preservative-free cyclosporin is also good for the patients. It epithelializes and regularizes the surfaces also, and makes the ocular surface a little less inflammatory if we are proceeding for a ablative surgery. And if the patient does not have any quantitatively dry eye and has developed, especially after the surgery, then I try to look for the causes if there are any dry spots. And so upping the lubricants or giving some gel drops or ointments at night, and also mentioning the patient's screen time. So I tend to take that also into account if he has a lot of screen time. So I try to give him some home-based exercises or 20-20-20 rule. And if all this is failing, then we can go for the IPL therapy or the lipid therapy in most of the patients, which also does good in some patients.
You routinely use intense pulse light therapy prior to your surgical
Not routinely, but if the patient is very symptomatic, and then maybe in some cases. But I have still not done in any of the cases. Most of the patients are controlled by drops. But if there is any patient who requires it, I would probably do it before sitting procedure.
And how long do you tend to wait in optimization, the
3
process of
months.
optimization?
I would wait 3 months, because it is seen in studies also that even if we are using trehalose as a drop or sodium hyaluronate as a drop, the effect comes after 3 months, and especially with cyclosporin also. 3 months is the minimum time I would wait for it.
Okay.
Ma'am, one thing that I want to ask is let's regarding the FDA approved age of refractive surgeries. So LASIK and all, it's 18, but ICL is 21. So if
21,
you
yes.
have in your OPD a patient who is, let's say, 20-year-old and wants to come for an ICL, or a 17-year-old with a stable refraction, would you proceed with refractive correction, or what are the ethical guidelines regarding that, ma'am?
So by the Indian Council, there's no guidelines which are given. These are given by the USA approved. But obviously, the Indian ophthalmologists also continue using this. So I would suggest we should rather stick to it. And because if something goes wrong and if it goes in the court of law, then the legal team is not going to stand behind you if you are doing this ICL surgery in a 18-year-old person. So it's better to wait for the FDA guidelines and then to proceed for the surgery.
Dr.
Thank
Ritika,
you.
one more question which just pops into my mind right now
Yes.
is there are certain off-label, surgical procedures which are not FDA approved, like the topography guided
Yes.
customized images followed by a cross-linking procedure. So
Yeah.
cross-linking is FDA approved. PRK is an FDA approved procedure, but combining both, especially in cases
It's
of
not.
keratoconus
Yes.
or not, is not. So what is your take on such cases, and how do you expect to inform your patient, or how do you counsel your patient for the same?
So, I would suggest that when the patient comes to you, we can give him options, and backing it with law is not there, but we have a lot of peer-reviewed research papers which have been done. So that might be helpful in our counseling that, other centers have done this, other research team has done this. So we can also go ahead and do this, but not promising any refractive results, obviously, because TCAT will not give us any refractive results. We are only doing it to regularize the cone. So we can counsel the patient in that way that we are doing it to regularize the cone, and then we will do a FDA approved CXL procedure. But the only thing is, if we are going to a court of law, we are backed by a peer reviewed research papers and no FDA regulations. So that might be a problem.
So we have, I think, probably a question from one of our fellows who's asking the cutoff for PRK, I believe. That's what is being asked, right? So what are your cutoff values for various procedures that you tend to use?
So a refractive cutoff, or they want a pachymetry cutoff? Refractive cutoff.
Pachymetry cutoff and the refractive cutoff for various.
So pachymetry cutoff always depends on the residual stromal bed thickness. So even if the patient is at a pachymetry of 490, but the power is of minus 1.75 and he wants it for a professional job or something, we can explain it to him that he has a thin cornea and then proceed with him, or also do a PRK extra procedure for him, which can be combined with a cross-linking, which is a short cross-linking for him. And refractive values is, for me, I do not proceed in PRK more than -5 on the lieu of scarring, and a cylinder of more than -3. So that is my refractive cutoff. But I know I'm on the safer side. You can proceed with up to -7 also. Ma'am, you're muted, I think.
What about corneal thickness of 490 and a silk or a smile?
Ma'am, also depends on the residual thickness bed and also the lenticule thickness, I would say. So if the lenticule thickness is very less, then we can attempt, but 490 with a power of -3, I would not go. With a power of -1.5, maybe I would go for it.
Although I think that would be difficult to defend if
Yeah.
law-wise,
Law-wise, if we go to
it'd be
it.
difficult to defend that by you did a
It
cell.
actually depends patient to
Residual
patient. I
stromal
mean,
bed.
all cutoff values changes from patient to patient.
So I think another good rule to follow apart from the RSBT is also the PTA. How much
PTA,
of
yes.
percentage of tissue are
Percentage
you
thickness
want to take
alteration
care of?
also.
Yeah.
Yeah.
So that is also a very important rule to follow, and a mix and
Yes.
match between the two will be rather helpful in deciding the correct course of action for the patient at hand. And I mean, to my limited experience of past almost 15 years, I think your bailout surgery in most of the circumstances is a PRK or an epicontura
Yes.
as compared to any other surgery.
Yes.
And now that we are having the Amaris platform and we are able to perform the smart surface as well, the results are pretty good and the recovery time of the patient is also pretty truncated.
Yeah.
So, Ritika, any other things that you would like to say?
Which Ritika? I think there's a. So I think one more point that I think is that I think it might help to share the consent form with the patient beforehand so that they can go through it, because usually on the day of surgery there is a lot of rush and there are
Yeah,
other
we
things
generally
happening.
give the consent to the patient to read
Be
and then
home
come
and
back
read.
and explain to the patient by the counselor and also by the doctor. So generally there are 2 or 3 sittings before the patient has booked the surgery. So the patient comes back after retina screening, after any other screening, he has talked to some other doctor and comes back from the counselor with some questions. So 2 or 3 sittings with the patient is required to convince him for a refractive surgery.
So you are giving the consent to the patient as a takeaway prior to
Yeah.
the surgery.
Yes.
1 day prior to the surgery.
1 day prior to the surgery.
I think that's a very good practice.
Yes.
Yeah. So that gives the patient ample amount of time to come back with the questions that he has
Yes.
on his.
Yeah.
They're not able to go through it on the day off. There is payment, there is shifting and everything. So I think it's a good practice to have.
Yes.
Right. So I think it has been quite a fruitful session, and we have all learned a lot today. And
Hopefully no
we are
lawsuits in the future.
yeah, I sincerely hope so. Sincerely wish that upon everybody. I sincerely wish lots and lots of wisdom to all of us and to the patients as well, and lots of kindness also to all of us and to all the patients. Because I think empathy is one important aspect which is going to help you in most of your situations.
Yes.
Just trying to be in their shoe and trying to make them understand your perspective as well. So, yes, it is a tough branch. Ophthalmology is very nice, but it's a tough branch in this regard because we are doing lots and lots of procedure in a single day.
Yeah.
Yeah. So in orthopedics, you're doing say maybe 2 surgeries in a day. In gynae, you're doing maybe 1 surgery in a day. But in ophthalmology, you may land up doing 5 to 10 procedures in a single sitting, in a span of few hours. So the time duration that you're spending is very less during the surgery. However, the explanation, the counseling, the taking care of the patient is as elaborate or more. And we are dealing with one of the most important organs of the body, without which the world is bleak. So we have a huge responsibility on our shoulders, and refractive especially is happening in totally virgin eyes. So very, very important that a clear communication with the patient of the expectation and the goal of the surgery should be met with, and the patient and the doctor at all times should be on the same page.
Yes. Also, the patients are very young when we are dealing with them. They might be a little bit more immature as compared to the cataract surgery patients who are more matured in their elder age, and they are happy with whatever vision they are getting after the cataract with the rest of their life. But the patients are more demanding when it comes to refractive surgery also.
Another thing that I generally tend to do in my practices, I generally ask them to have one, you know, a kin, next of kin, or
Yeah.
a family member,
Yes, that's very
or a
important.
very close friend who's listening to all the conversations. And
Yes.
many times on the paper itself, I tend to draw everything and
Yeah.
explain them that what is the expectation of the
Yes,
surgery,
yes.
the
Same,
test
ma'am.
date. So that is all written on the patient's paper, and tomorrow patient cannot come and tell you that you had said ki 6/6 vision aayega.
Hmm.
So that should
And
not
also explaining their own amblyopia to them, because some of the high myopes are amblyopic. Some might have some squint issues, some have some orthoptics issues. So getting that ruled out is also very important these days.
We are very lucky to be working in an institutional setup.
Yeah.
So it's very important, to be covering up all the aspects.
Yes.
Forget the glaucoma, don't forget the retina.
Hmm.
Bypassing steps is very easy.
Yes.
Skipping one step is going to have can have a very catastrophic, result in a later date. So important to be thorough when it comes to your workup. And you must follow like we have a very nice yellow file in which we document everything about the patient's readings, including, PACI, their retinal examination, their corneal readings, their examination, which is happening on the pentacam, on the corvis. So everything is well documented on a single sheet, and there is a checklist. So you don't tend to miss points. And even otherwise, you have to make your own mental checklist or a written checklist to be more thorough, so that you are not missing on the most important aspects of the patient's vision correction. All right. So I think Dr. Ritika Mukherjee, anything that to add or you would like to say?
No, I think we've had a fruitful session and a lot of things were discussed. Thank you.
Yeah.
Thank
So
you,
we look
iFocus,
forward
for
to
this platform.
Yeah.
It was very encouraging to join you all.
Thank you very much, Dr. Ritika, for an insightful session.
Thank
And
you, ma'am.
I think we can call it a day. Thanks a lot.
Thank you.
Thank you.
Thank
Good
you.
night.